several causes of lack of insufficient capsular support. They are stated here, and for this state there are some different corrections used, but all of them have several well-known disadvantages. And considering that these disadvantages, we have designed in cooperation with Acrytech Germany a new foldable one-piece acrylic anterior chamber lens. This lens is injected with a NaviJack injector and NaviGlide cartridge through the 2.8 mm clear corneal temporal incision. We have implanted this in more than 20 patients, but this is we are presenting the group of consecutive 13 patients. In 6 of them it was implanted during the pars plana vitrectomy with phacofragmentation for severe crystalline lens subluxation or luxation. In 2 cases during pars plana vitrectomy for the removal of luxated IOL. In 2 cases during phacoemulsification due to large capsular rupture, and in 3 cases as a secondary implantation in aphakia. The follow-up time ranged between 4 and 36 weeks, and here you can see 4 examples of post-operative view. No intraoperative complications were seen. Post-operatively, the best corrected visual acuity has improved in all patients. Best corrected visual acuity that we have achieved was between 0.2 and 0.5 in 6 cases, and between 0.8 and 1.0 in 7 cases. Mean postoperative percentage of corneal endothelium cell loss was 15.7%. We have seen some postoperative slight complications like transient corneal edema, delicate pupil deformation, small choroidal emosure, and transient rise in intraocular pressure. And conclusion, the early initial outcomes indicate that implantation of the new foldable anterior chamber intraocular lens through a small incision is an effective and safe method, being an alternative for rigid, all PMMA anterior chamber intraocular lenses and scleral fixation intraocular lenses in aphakic eyes. Thank you.
Thank you very much. Dr. Montesmico is going to present a new intraocular lens for achromatizing the human eye.
Chairman, moderator, thank you. I'm going to show you a new design of IOL capable to correct chromatic aberration when we implant it in the human eye. You can read it if you want deeply in the Journal of Cataract and Refractive Surgery. Well, these are the factors which affect the human spatial vision. We have neural network, eye optics, photoreceptor mosaic. Considering eye optics, we have diffraction, aberration, and scattering. Focusing on aberration, there are monochromatic and chromatic aberration. We will try to correct higher order monochromatic aberration and chromatic aberration using this new design. Well, why to correct chromatic aberration? We have several advantages. First of all, it's similar for all the subjects. It doesn't not change with age. And we have high theoretical improvement in the optical quality of any system when we correct the chromatic aberration. Disadvantages also is expensive and thick designs, all designs using doublets or triplets, and is high sensible to the centering, considering the transverse chromatic aberration. Well, the new design considers the dispersion by refraction and the dispersion by diffraction. Combining both, one compensates the other using a refractive and also a diffractive surface in the first or in the second surface. And we create an achromatic singlet, refractive, diffractive. These are the results that we have. Comparing with standard spherical IOL, you can observe the polychromatic MTF, and you can observe that the polychromatic MTF in an eye when we center it, no tilt at achromatic IOL, is near to the diffraction limit. If we focus on the focus shift for the visible spectrum, we have a variability of the focus of this focus shift above 0.1 diopter in contrast to the spherical standard IOLs about 1 diopter. This shows the improvement in the focus shift and obviously the optical quality of this new system. About to the robustness to the centering and tilt, 2 graphs to show you the same IOL, when we decenter several degrees, several millimeters, and we tilt it several degrees, you can observe how it changes, considering both graphs and being a main conclusion for both graphs. The polychromatic MTF in an eye, when we implant in an eye this IOL, will be similar to that in an eye with a spherical centered IOL if the achromatic were the center 1 milliliter or 44 degrees. In conclusion, the design of the new IOL is capable to correct spherical aberration and also chromatic aberration when we implant in the eye. However, we need to create new prototypes and to check that this improvement in optical quality is followed by an improvement in the visual quality of these eyes when we implant it. Thank you.
Thank you very much. It's my pleasure to announce Liliane Werner, the co-moderator here, and she will talk about a photochromatic intraocular lens.
Thank you very much. Good afternoon.